The second lesson in this learning module on physical health and related low-incidence disabilities will cover other health impairments. Other health impairments means having limited strength, vitality, or alertness, including a heightened alertness to environmental stimuli that results in limited alertness with respect to the education environment that is due to chronic or acute health problems such as asthma, attention deficit disorder or attention deficit hyperactivity disorder, diabetes, epilepsy, a heart condition, hemophilia, lead poisoning, leukemia, nephritis, rheumatic fever, sickle cell anemia, and Tourette syndrome, and adversely affects a child's educational performance. The etiology or cause of other health impairments can be categorized by chromosomal and genetic causes, teratogenic causes, prematurity and complications of pregnancy, and acquired causes. Chromosomal and genetic causes are hereditary causes, such as muscular dystrophy, sickle cell anemia, hemophilia, and cystic fibrosis. Teratogenic causes include outside causes, such as infections, drugs, chemicals, or environmental agents that can produce fetal abnormalities. Prenatal infections that may result in birth defects are referred to as TORCH, or toxoplasmosis, other, rubella, cytomegalovirus, and herpes. Effects of any of the infections can vary from none to severe disability or death. Prematurity and complications at birth can cause neurological problems, cerebral palsy, epilepsy, vision loss, hearing loss, deaf blindness, and/or psychosis. Cognitive functioning can also be affected. The most common cause during the prenatal period is asphyxia. Acquired causes include trauma, abuse, infections, environmental toxins, and disease. How many conditions are we talking about under other health impaired? Really, any medical condition can qualify a child under other health impaired if it has an adverse effect on their educational performance. Other health impairments can give rise to emergency situations that need to be handled immediately. Some can be treated effectively, and some have no cure. Your book talked about two major health impairments that often fall under the category of OHI, including seizure disorders and asthma. A seizure is a sudden temporary change in the normal functioning of the brain's electrical system as a result of excessive and uncontrollable electrical activity in the brain. Seizures may result from high fever, ingestion of certain drugs or poisons, metabolic disorders, or chemical imbalances. Asthma is the most common pulmonary disease in children. Children with asthma breathe normally until they come into contact with a substance or situation that triggers an attack. This could include dust, pollen, infection, or exercise. Asthma is treated with a combination of fast-acting and preventative medication. Oftentimes, an asthma attack will stop after using a fast-acting inhaler like albuterol. However, sometimes they will persist. When an asthma attack persists, it is important to call an ambulance and get the child medical attention immediately. Infectious disease also falls under the category of OHI. Some diseases are transmittable and others pose no threat in school. The important thing to understand with infectious disease is that modifications and adaptations may need to be in place due to extended absences from school and side effects as a result of the infectious disease. We are going to focus on two main conditions given the number of impairments and diseases that could qualify a child to receive special education services, including seizure disorders and asthma. As we said earlier, a seizure disorder is an illness that changes the way the brain works while in the seizure state. Seizures occur when a surge of electrical energy occurs in the brain. Seizures vary by type and can cause changes in the way a child feels, moves, and acts. The duration of a seizure can last from a few seconds to a couple of minutes, with a return to normal state shortly after the seizure ends. It is important to note that epilepsy is an illness characterized by recurrent seizures and not a single one-time event. Children with seizure disorders may experience episodes of blank staring or may fall, shake, jerk, and stiffen in parts or all of the body. After the seizure, children may experience mood changes or confusion. There are several different types of epilepsy or seizures. The type of epilepsy is generally diagnosed based on the area of the brain affected. In order to identify the type, doctors will do an EEG or electroencephalogram to determine the part of the brain that is affected. Seizure disorders are present in about 50% of the population of individuals with intellectual disability. However, epilepsy is not associated with intellectual disability. Seizures can be divided into two categories, location and type. The first variable is location within the brain and whether it is localized to one part of the brain or the entire brain. If it is localized to one part of the brain, it is a partial seizure, and if it involves the entire brain, it is a generalized seizure. The second variable involves the type, simple or complex. Simple referring to part of the brain and/or body affected, and complex referring to involvement of the entire body and/or brain. Partial seizures are further divided on the extent to which consciousness is affected. If consciousness is unaffected, then it is a simple partial seizure. For example, a person remains fully conscious, but maybe their arms shake uncontrollably for a few minutes. In a complex partial seizure, only one part of the brain is affected, but consciousness is affected. Also noteworthy, if a person has a complex partial seizure that is affecting the temporal lobe, then the person can actually begin to have hallucinations. Some have termed these Alice in Wonderland seizures because the person loses grip on reality. They may begin talking nonsense and may be very confused. If a child starts to act very strangely, it could be that they are having a complex partial seizure that is stemming from a seizure in the temporal lobe. Generalized seizures are where the entire brain is affected. There is no such thing as a generalized simple seizure because if the entire brain is affected, then the entire body is going to be affected. By definition, anyone who has a generalized seizure will experience a lack of consciousness. There are two types of generalized complex seizures that you need to know about: absence seizures and tonic-clonic seizures. Absence seizures usually last from 2 to 15 seconds and may occur a few times to 100 times a day. They usually present themselves as periods of staring off and are often mistaken for daydreaming. Afterwards, the individual will not likely have memory of what happened. As a teacher, it is important to make sure that a child receives information that may have been missed while in the midst of the seizure. Generalized complex seizures, such as tonic-clonic seizures, are what people typically think of when they envision a person having a seizure. The body becomes very rigid, the person falls to the ground, and then they go into convulsions. The convulsion state of the seizure should not last for more than 5 minutes. After the seizure has subsided, the individual may need to rest. Effects of the seizure can last from a few minutes to a few hours. It is important to understand seizures and what to do if a child has a seizure. If a child has a seizure, you want to try to break their fall if possible and turn them to their side to keep the airway open. It is also important to cradle their head with your hands or something soft to keep them from banging their head against something. You also want to time the seizure to make sure it doesn't last more than 5 minutes. If it lasts for more than 5 minutes, you need to call 911 and get emergency personnel at the scene. It is also very important to stay calm and supportive throughout the entire event. As we said in the last slide, in the event of a seizure, it is important to stay calm. Do not overreact or become overly upset. Never put anything in the child's mouth. A person having a seizure is likely to clench their teeth together, so we don't want to put anything in their mouth that could hurt them or you. It is also important not to hold the child down during the seizure. Beyond turning them on their side and cradling their head, you should let them go. Lastly, refrain from giving the child food, drink, or medication before he or she is fully awake. It may take a few minutes to a few hours before the child is fully recovered. The following video provides further information about seizures.
Each year, more than 350,000 children from birth to young adulthood suffer some type of seizure. Many of these are treated and cared for at Children's of Alabama. This video will teach you about different types of seizures and what to do if your child has a seizure. You will learn about the following: febrile seizures, infantile spasms, focal seizures, drop or atonic seizures, myoclonic seizures, absence seizures, formerly called petit mal, and generalized tonic-clonic seizures, previously known as grand mal. A febrile seizure is a seizure caused by a fever and is not considered to be epilepsy. Up to 5% of otherwise healthy children between the ages of 9 months and up to 6 years will have a seizure caused by a fever. Most febrile seizures occur within the first 24 hours of an illness. Common signs of febrile seizures often begin with a sudden cry, stiffness, followed by jerking of the body, and usually last only a couple of minutes. In this example, notice how both arms of the 1-year-old boy are raised and stiff. His eyes and head are jerking. His whole body is involved. Even though his mother is talking to him, he is unresponsive and unaware of what is going on. Infantile spasms. During infantile spasms, the infant has quick and repetitive movements, which can be numerous. This 3-month-old boy is having a cluster of spasms indicated by the extension of his arms. You have to watch closely to notice the seizures, which is why infantile spasms are not easily seen. Infantile spasms occur between 2 months and 2 years of age. Appear in clusters often when waking up or falling asleep, and can be mistaken for hiccups, colic, or a bad stomach ache. Here's what to do should your child have an infantile spasm. Note how many spasms occur. Call your child's doctor immediately if you think your child is having a spasm. Focal seizures are also called partial seizures because only a portion of the brain is affected when the seizure begins. Common signs of a focal seizure include a blank stare, altered awareness or seemingly being out of sorts, repetitive behavior such as chewing or picking at clothing and mumbling. In this example, the boy's eyes are open, but he is unaware of his surroundings. He is unable to follow simple commands. Focal seizures can last a few minutes. There may be a time of confusion afterwards that can last much longer. Many children are sleepy and may not remember the event. What you should do: speak calmly and remain with your child until the seizure is over or help arrives. Do not try to hold your child during the seizure. Call 911 if symptoms persist. Sometimes these seizures may progress to a more serious type of seizure, which we will discuss later. Drop seizures or atonic seizures cause a sudden loss of muscle tone. Here are common signs of atonic seizures. The child stumbles or falls, which can cause injury. The seizure may be mistaken for clumsiness or poor coordination, since the child will usually recover within minutes and be able to stand and walk again. Watch this 3-year-old boy as he stumbles and falls back in this sequence of seizures. Here, the child's head drops and he falls backward. He continues to have seizures while sitting in his mother's lap. Notice as his head drops forward, similar to that of catching oneself before a fall. Call your doctor immediately if your child has these symptoms. Some children who have atonic seizures will need to wear headgear for protection from injury. Myoclonic seizures cause a sudden jerk and usually happen in the morning. In this example, the child is having sudden jerks of his upper body as he sits at the breakfast table. Call your doctor immediately for help. absence seizures. Watch this 7-year-old as she does her homework. While writing out her assignments, her hand suddenly stops. She looks up and briefly stares into the distance. Common symptoms of absence seizures include a blank stare that begins and ends abruptly, lasting only a few seconds, rapid blinking and chewing, unawareness of what is going on during the seizure with a quick return to full awareness after the event, can occur a few or up to hundreds of times a day, and are often mistaken as daydreaming or poor attention. Here is the same child at a horse show. The excitement and anxiety of the event result in a mild seizure. Notice how she steps forward briefly. She almost comes to a complete stop, then goes on to participate, unaware that she has had a seizure. While children with absence seizures frequently have trouble in school, the majority respond well to treatment with seizure medications. A large part of the brain is involved in generalized tonic-clonic seizures. Tonic means stiff and clonic means jerking. Generalized tonic-clonic seizures are the most dramatic of all seizures. They often begin with a sudden cry, a fall, rigidity or stiffness, and muscle jerks. They usually last only a couple of minutes, and the child may be irritable and sleepy for minutes to hours afterwards. This 4-year-old has lost consciousness and is stiff. Notice that his head is turned to the left and his eyes are fixed to the right. The jerking is intense and his entire body is involved. As the seizure comes to an end, you can see that the jerking is gradually slowing to a stop.
Children with epilepsy have the same range of intelligence as other students. Epilepsy does not cause academic difficulties. However, if academic problems do exist, that may result from medication side effects, anxiety, multiple school absences, underlying neurological issues, the seizures themselves, and the teacher's attitude. It is important to monitor the learning, behavior, and emotional well-being of students with epilepsy and communicate information about any changes to parents, doctors, and any other individuals working with a student. Medication can affect any of these areas, and it is important to maintain communication. Remaining calm and educating students in the class about epilepsy will help reduce anxiety. It is also helpful to develop a system for the student to make up missed work. As a result of underlying neurological issues, teaching strategies, visuals, and repeating verbal information may be helpful in continued academic growth and achievement. Buddy systems may also work well in assisting the student when a question arises or missed work and assignments need to be explained. Lastly, it is important to remember that individuals with epilepsy have the same range of intelligence as their peers. Teachers should strive to maintain high expectations. On average, a typical classroom of 30 students is likely to have 3 students with asthma. According to the 2004 National Health Interview Survey, parents reported that 9.6%, or 5.1 million, of their school-aged children, ages 5 to 17, had been told by a doctor that they have asthma, and still had asthma. So what is asthma? Asthma is a condition that is chronic, meaning that it is an ongoing, long-term condition. It produces recurring episodes of breathing problems called asthma episodes. Asthma can be potentially life-threatening and can occur at any age. It is not contagious, meaning it cannot be spread from one student to another, nor can it be cured. It can, however, be controlled. The cause of asthma is unclear. It is probably caused by a mix of genetic and environmental factors. Genetic factors are things passed down from your parents. Environmental factors are things in the environment around you that may contribute to the development of asthma. What are the symptoms of asthma? Symptoms include shortness of breath, where the student may complain of being winded or can't catch their breath. Wheezing, which may sound like a high-pitched, raspy whistle, is another symptom. You may hear the wheeze when the person inhales or exhales. As the episode progresses, you may hear the wheeze when the person inhales and exhales. Tightness in the chest may also be present. Some kids may describe this sensation as heaviness in the chest. Coughing at night or after physical activity, or a cough that lasts more than a week, can also be a warning sign of an impending episode for some people with asthma. Waking at night with any of the above symptoms is a key marker of uncontrolled asthma. These nighttime awakenings may manifest during the day as a child being tired at school or demonstrating an inability to focus. One or more of these may be present, and the absence of wheezing may mean there is no air moving through the lungs at all. 3 things can happen during an asthma episode. First, swelling of the airways can occur as a response to an asthmatic trigger or something the child is allergic to. Next, mucus builds up and blocks the airways and thus allows less air to pass through the airways. The air passages are squeezed together by the muscles that surround the outside of each airway. This combination of swelling, clogging, and squeezing dramatically reduces the size of the airways. Student learning can be impacted by fatigue, absenteeism, or symptoms that interrupt students' attentiveness. An asthma episode can be distracting and upsetting to other students and staff. Students with asthma sometimes experience lower self-esteem, and academic success can be affected by the missed class time and absenteeism. Some students with asthma feel anxious about participating in physical education or other activities because they're afraid they will experience an asthma episode. So how can we help students control their asthma at school? Follow an individualized written asthma action plan. Each student's asthma action plan should come from his or her physician or other healthcare provider and be signed by parents and school nurse. If a student in a classroom is sensitive to specific allergens or irritants, reduce or eliminate those allergens or irritants. Encourage students to use their asthma medications as prescribed. For some students with only occasional symptoms, this may mean using just a quick relief medicine to relieve symptoms. For others, it may mean using daily long-term controlled medicines as well as quick-release medicine when needed. To help students control their asthma, we can also monitor students' response to use of their quick-relief medicine by noticing symptoms and having them measure their breathing by using a peak flow meter. We can also monitor level of asthma control and encourage students to seek medical care when they experience asthma symptoms. Furthermore, encourage regular communication and health updates among the school, the student's doctor, and his or her parent or guardian. Creating an asthma-friendly school will be key to supporting individuals with asthma. An asthma-friendly school is one that is free of tobacco smoke all of the time, including during school-sponsored events. It is also a place where students are permitted to take medicines at school as recommended by their doctor and parents. If some students do not carry their medication, they should quickly be able to find and use them. Lastly, written emergency plans for teachers and staff to follow should be in place to take care of a student with an asthma episode. This plan should include what to do, who to call, and when to call. Furthermore, in an emergency, such as a fire, weather emergency, or a lockdown, or if a student forgets his or her medication, the school should have quick relief medicines for students to use. It is important to have a school nurse available all day, every day, and at the very least, the ability to contact a school nurse. Maintaining good indoor air quality and modifying activities environments that cause problems will also be essential for students with asthma. Every school should have a specific plan for handling asthma emergencies for students without an asthma action plan. Probably the most important thing any school staff member needs to know is how to handle an asthma episode. For some students, this can prevent a visit to the emergency room, hospital, and in the most severe cases, it can prevent them from dying. Steps for handling asthma symptoms at school include following the student's asthma action plan or the school's written emergency care plan. These plans usually involve evaluating the situation and calling 911 if the student is in severe distress. Encouraging the student to use their medication as directed, in addition, calling the school nurse or other designee if the student does not carry the medication. Before we end this lesson, take a minute to review this slide.